welcome everyone. Thanks for joining our latest expert seminar. I'm really excited that tonight we've got Dr. Ana Brito, who's going to be covering sleep disorders. So this is really not in terms of so much of a clinical sense, but to give an idea about in terms of when children are having problems with their sleep. Sometimes they do manifest themselves as sleep disorders, so kind of covering what do we mean by these sleep disorders, what are the common types, and what are the kind of things to watch out for, and what are the kind of actions that we can take, especially as sleep practitioners. It's kind of a very useful session. All right, so Dr. Ana Brito, in terms of just introducing you. So Ana, you've been working with the London School of Childcare Studies, so quite recently joined us and is a trainer on our sleep practitioner program, but has got many years of experience in sleep physiology and sleep practice. And the last 4 years was working at the Evelina Children's Hospital at Guy's, and that was in the sleep medicine unit. So yes, I know you've got loads and loads of knowledge and experience firsthand of looking at sleep disorders in children. So with that, I'll hand over to you, Ana, and we'll get this session started.
Thank you, Chris. Thanks for the introduction and welcome everyone. So what I bring today is just some notes around what to look for when when we might be in presence of a sleep disorder in a child, and what kind of tools and techniques are out there, not only that we can easily put in practice, but also if you're going to work as a sleep practitioner, or if you work in different medical settings, for instance, maybe should be able, you can use it or advise what kind of tools can be used. Mainly today we're going to be talking about healthy children. So we're not talking that much, of course, that these conditions and the signs that we might see, they're transversal, so they can be seen in healthy babies and children, and in children with medical conditions. But usually those children with additional medical conditions, we have further sleep challenges. So we might have more sleep challenges there present, and sleep disorders. They're very typical in some health conditions. And those, they usually come to us, to the diagnostic sleep services quite early in the days. But you might know a family, either in a school setting or as a sleep practitioner, that you might start noticing some signs of something a bit more serious going on with their sleep that you might want to explore. So we're going to talk about the most common sleep disturbance and sleep disorders in children. And one I've kind of divided this is because, as probably most of you know, there are some sleep issues or sleep challenges that we might see, especially in babies in their first year of life. And there's sometimes they present their sleep to be disturbed, or they might not rest as expected by the parents. And we're gonna, there's sometimes a lot about expectations. But there might be things on their environment, on their routines, that might actually get on the way, and they're kind of disturbance. But it doesn't mean there is actually a sleep disorder there. And in adults it happens the same, but in children it happens even more. The aspect of dual diagnosis, that sometimes the signs can actually indicate us different disorders, and sometimes the signs around sleep disorders, they might pair up with other things that we want to look into. We're going to talk briefly about the impact of sleep disturbance, especially in older children as they grow. We might notice changes in their behavior and their school performance, for instance. And so we're going to look very briefly how that can impact their development. And how we can do a sleep evaluation. We always recommend a systematic approach. There's some very useful tools like questionnaires and scales And we're just going through probably more detail through the BEARS screening questions, which is a very cool tool that, despite doesn't allow us to make a diagnosis, it actually help us to see if there are signs of potential sleep disorders. And we're going to talk briefly again about the use of sleep diaries. If you're on the sleep practitioner course, you know that we talk a lot about the sleep diaries. And I'm just going to show you just a few pictures and give you a bit of information about some objective sleep measures we have in the sleep labs to help us to diagnose the sleep disorders and to monitor their involvement. And then we're going to talk about some pathways as well, how usually a patient that might present a sleep disturbance is not usual for their age group, or they might present signs of sleep disorders, what kind of pathway they can follow to be properly diagnosed and get the treatment that they need. So when you talk about newborn age, so we're talking about from not to 2 months, it's very important to keep in mind that when a newborn arrives, and even if they're full term, their body clock, their circadian rhythm that regulates their sleep is not quite ready yet. So these day and night, their sleep doesn't follow the day and night kind of system that we all have and all the children will have. And sometimes the kind of issues that we find is the day-night reversal, especially within these first few weeks. Again, is expected in a way, but again, is about parents' expectations as well. And sometimes parents' expectations, they're not in line with what the child is actually ready to do. There's also, and that of course, it translates itself as irregular sleep patterns that can last up to 2 or 3 months. The sleep environment and safety, that probably the things that we might really want to look into if we come across a family with a young baby. So the sleeping position, the environment, the surface where they're lying down, they're probably the most important aspects, but also general environment, how are the parents coping, and if there are any health conditions or complications that actually might impact their sleep. The most issues, again, it is about the discrepancy between what the parents are expecting or the carers are expecting and their behaviors. With time, the parents should be encouraged to recognize the sleep habits and patterns for their child. But again, they will change with time, but as a newborn, after a couple of weeks, they usually start to recognize their little patterns. Go up to infants from 2 to 12 months. There's some other things adding up. So we might start with some issues of attachment, and because the social interaction is bigger and bigger as they grow, they also, of course, play a big role in shaping the sleep behaviors. It's about also getting into some routine about the daytime sleep, and of course, a routine about nighttime sleep. It's actually estimated that about 25 to 50% of the children from 6 to 12 months and about 30% of above a year, they continue with problematic night awakenings. So the night awakenings, they are the most common sleep challenges with this group. Like I said, even sometimes after they turn 1, they're still there. One of the reasons for that, it could be feeding challenges. So maybe there is a baby that still wants to feed through the night. It could be some other conditions, health conditions. But it's at this age where they start to come up with some sleep-related rhythmic movements. I don't know if you're familiar with, but sometimes they might bang their head in a rhythmic way in a specific part of that night. They might rock their body to trying to settle themselves down, and that can disturb a bit the night by they basically need to go back to that rocking behavior if they wake up. It's important to support the sleep regulation and or the self-soothing at this age. So from 2 months old, usually later when they're around 4, is important to help them with that, and to start embedding that nighttime routine for them to have some cues, some sleep cues to help them to initiate sleep. During the night, we also have the common arousals that might come up. If they need, it'll be different. They'll be managed in a different way if that child can actually self-soothe, or if they need any support with that. And how much is the parental intervention there? Older children from 12 months to 3 years old, so on the toddler kind of bracket, there's massive things happening with their development, of course, gross motor development, cognitive development, language, social, emotional. So this interaction in a way, or the influence of this into their sleep, it'll be bigger. So it's important those 3 hours before they go to bed to pay attention to that. And the common sleep issues are the problems with the timings of the naps and the sleep pressure, transitions from the crib to bed, and again the night feeds that might be still a problem in some children. The sleep problems in this group, they're very common. About 25 to 50% of this age group still present some sleep challenges. The bedtime problems resistant usually start. Nighttime awakenings is quite high still. And again, the sleep-related rhythm movements, these can continue until they go to school, and parents might refer, or even the school staff or nursery staff might refer that when they're sleeping, or they're falling asleep, they're rocking their body, or whilst they're apparently to be asleep, they're banging their head or rocking again. So it could be a side of this. So older children, again, if they're sleep challenges, especially nighttime awakenings and bedtime resistance until 3 years old, if they're not addressed, that is just going to tends to get worse. So it's important that we're trying to support these families. The co-sleeping and the parents' presence, again, might reveal some separation anxiety and some attachment. It's important to help them to keep the sleep schedules and to enable an appropriate bedtime and to avoid the overtiredness. The common sleep disorders in this age group, there are the difficulties with settling, but also nighttime awakenings, they're still very common. And the nightmares and the nighttime fears, they usually start at this age. And it's usually at this stage, despite, and of course, they can be noticed and diagnosed beforehand, but the majority of the children that we see probably coming in for trying to diagnose or exclude obstructive apnea, for instance, is usually in this age group. There might be health conditions, genetic conditions, for instance, that might actually lead to other kind of sleep disorder breathing, things like central apnea and other sleep disorders related with the breathing. And knows early in the days because the child might show signs of that much earlier. Quite often we see what we call the disorders of arousal. So we're talking about sleepwalking, sleep terrors, for instance, they might come up. And we might start seeing children, even during daytime at school, showing some signs of insufficient sleep or disturbed sleep, which quite often reveal themselves as behavioral problems then during the day. Their focus, their concentration span, might show some problems, and also some behavioral issues during the daytime with colleagues and even with the teacher. We have another problem these days, well, I guess the last 10 years, maybe less, is the electronic exposure and the level of stimulation that these children have. Unfortunately, I think it happens much even earlier than 3 years old. But at this age, the majority of children have a lot of exposure already, and the level of stimulation at the end of the day as well. And it's important to start some sleep education, not only with parents, but with children as well. During March, during the World Sleep Day, I had opportunity to give a workshop to schools with some groups of children, some of them with 3-4 years old, and then older children. And, you know, in a funny way, we talk about sleep and about how sleep is important and what impacts sleep. And I was shocked with the amount of children that say they watch cartoons until quite late in the evening, even in bed. So, and then I know the feedback is that they went back home and told parents that they can't watch cartoons at home and, you know, in bed anymore. So it's with young age that we can actually start with sleep education. The school age children, by the way, this data is actually taken away from a book that I'll show you at the end. Undel, I think, is very much European because of the school age. Because we know in the UK they start nursery at school when they're 4 years old, so it's a bit of a mingle here. The common issues at school age are probably the irregularity of the sleep-wake schedules, later bedtimes as well. And the fact that during the night they ended up not having such a good sleep opportunity because of behaviors and because of habits as well. They start to be more and more independent from parents, and then can lead sometimes, again, a bit of resistance with bedtime, the increase on the social and academic activities, they can also have an impact. And again, the media and electronics exposure. We might be surprised with these statistics, but unfortunately it's quite young age to start introducing some caffeine intake, usually on soft drinks. But 40% until they're 12, they actually had already included in the diet some caffeine. The common sleep disorders, the sleep paralysis, there will be the sleep disorder breathing, and also some movement disorders whilst they're asleep, like restless leg syndrome or periodically movements. Quite often, usually it happens on their legs, so they'll be kicking their legs all night. Restless leg syndrome, they will have some symptoms whilst they're awake with discomfort on their legs, but that tends to make it difficult to go to sleep, but also to break down their sleep. It's quite common as well, some bruxism, so grinding their teeth during sleep, which is known to be related with some level of anxiety as well, but it could also be other factors contributing for it. And then we have the latest group of childhood, the 12 to 18 years old. We have the circadian factors. We know that their sleep needs change during this late stage of their childhood. Their body clock changes a bit as well, and the way they answer to sleep drive is different. They quite often they present symptoms, which usually it's just a transition, but they might present symptoms of what we call the delayed sleep-wake disorder. So basically the body clock tends to push them to go to sleep later and wake up much later as well. There are some countries that adopted in some schools a later school start to support children at this age. So instead of starting at 8, they might just start at 10, for instance. There's some schools up north, I think, in Scandinavia, that I believe they do that. There are also a lot of information about the burden of the chronic sleep loss in teenagers. We know that not only these physiological changes are happening, but then we also have a very social life at this stage, a lot of schoolwork, academic work as well. And again, a lot of exposure to electronics, even in bed, which in a way sleep deprives them. They don't give themselves the sleep opportunity that they need, and their body needs has different sleep needs as well. The kind of problems we see is usually the increase in sleep, insomnia is quite common. the delayed sleep-wake disorder, which again, it might be temporary, but we just push that body clock to be later. Obstructive sleep apnea, again, we see some very big changes in their body as well. So an increasing weight can come up and influence that sleep disturbance with their breathing. The restless leg syndrome and narcolepsy. Usually the narcolepsy, well, back in the days, narcolepsy, this is a neurological condition and they can fall asleep anywhere. It used to be diagnosed just in adulthood. I can tell you that Evelina, I think the youngest child that we tested, and there's specific sleep studies that we need to do, I think the youngest one they diagnosed was 4 years old. So we had very agile eyes from school and parents that they noticed there was something not quite right with the behavior from that child at that age. I think it was 4 to 5 years old. And then we actually able to, with the symptoms and with the test, we were able to diagnose them. So narcolepsy is something that can be diagnosed in childhood, and despite there's not a cure for it, there's ways of managing the condition and help these children and families to cope with a different condition. So this is just to show you that one of the things that might make it difficult in a way to pick up on is just insufficient sleep opportunity, or is that child presenting some sleep disorders, or is there something else going on? Because the different situations, the different scenarios, most of the times they will lead to the exact same thing, which is excessive daytime sleepiness. So we might have a bit of sleep restriction because that child for some reason doesn't have the sleep opportunity it needs for that age group. Or we might have something fragmenting their sleep. There's something creating a disturbance on their sleep architecture, and then they ended up not having a repairing sleep. We might be in front of a circadian rhythm disorder, or we might have a problem like narcolepsy, for instance, that causes the central disturbance. Or we might have a health condition that's actually impacting sleep that we're not aware. So in a way, if we see a child with daytime sleepiness, excessive daytime sleepiness, okay, we're not talking about 2 or 3 years old that they still need to do their daytime naps when it comes to their daytime nap. We're talking about very random times when they're showing signs of sleepiness consecutively, or we're talking about a school age child that is just falling asleep in their desk, or that just need to go to bed really, really early. So if that children, if they're not able to clear all the sleep pressure that they need to clear through the night through a good restorative sleep, the first sign will be a daytime sleepiness. So I'm not going to go through all of these in detail, but I will share later on actually the paper where I took this from. This is just an outline of, it's just a review of the main sleep disorders that will affect many children, and some details about how would they present themselves and how they can be diagnosed. Again, I'm not in too much in the clinical field, but I think it's important just to know what kind of diagnostics are out there to help those families. So I'll probably just pick up on the obstructive sleep apnea because it's probably one of the most common in children, because they come with big tongues sometimes, big tonsils and adenoids, and it's probably the easiest one for parents and even school staff to pick up. We usually have, there are also again some medical conditions that they're more prone for this, like any conditions that might affect the craniofacial or the airway or their muscles, their breathing muscles. So these children, they usually are snorers, especially if they are on their back, for instance, or if they're distended neck. They might show what we call the paradoxical breathing. So we might see whilst they're breathing that chest and tummy going opposite directions. That shows an increased breathing effort. So usually there's some kind of obstruction or limitation on the airway that is just making those muscles work harder. So it's quite typical in children that we can see that tummy and the chest going opposite directions. Sometimes children come to us at 7 and 8 years old because they still have nocturia through the night. So they might wet their bed and they just want to see what's going on, and it might be actually obstructive sleep apnea that is leading to that. Morning headaches. Again, they might present poor concentration, they might present no interest in playing or in some activities that require a bit more of focus. Again, the excessive daytime sleepiness. And again, usually when the doctors analyze, they might see they have big tonsils and big adenoids. So I will pass all of this information later to you, just out of curiosity. And again, the other one big group is probably insomnia in older children. Again, it's all about difficulties initiating sleep or maintaining sleep. And again, there's a lot of behavioral interventions that we can do here to help. The key issue, as I was saying at the beginning, is the fact that in the evaluation and management of the sleep disorders, it's important to have a differential diagnosis as many other conditions, because many sleep disorders present similar symptoms during daytime. Again, if we have parents saying that the child trashes a lot or talks in sleep, or there's pauses on their breathing, or kicks their legs a lot. So if families are able to pick up on those signs, that can help when the medical staff is doing the diagnosis. Encourage parents sometimes to do some little videos can help a lot. But during the daytime, when usually we can see the ricochet, we can see the influence of this. Again, they present very similar symptoms. And the sleep complaints, and the other way around as well. Sometimes we have complaints during sleep, frequent awakenings or pain, and they might actually be affected. Sleep might be affected, but there might be other reason actually that is influencing sleep. So we might need to actually differentiate the sleep disorder from other health condition that actually is breaking the sleep itself and not the other way around. And in many cases, 2 or more sleep disorders can come together. One of the pediatricians that works with us, Evelina, she says that sleep disorders in children, they come like London buses, they come 2 in a go. So quite often we see obstructive sleep apnea and leg movements, or we see narcolepsy and leg movements, for instance. So quite often they come not by themselves, let's put it that way. And sometimes children might present a sleep disorder, but there also might be some behaviors and environmental changes there that we need to interfere to help with the other sleep disorder, because the presence of one might exacerbate the other one and the other way around. So a few things that we usually see together, just out of curiosity, again, obstructive sleep apnea and enuresis, obstructive sleep apnea and passional arousal, the parasomnia. So again, they might seem awake, but they're not fully awake. The chronic inadequate sleep and partial arousals as well. The more sleep deprived in a way that child is, the more a possibility in a way there is for other issues to come up in sleep. The restless syndrome with the frequent kicks through the night again, and the delayed sleep-wake phase disorder might come up together or might be mixed up with a bit of insomnia as well. Again, to keep in mind the optimal sleep that we might be looking for ourselves and for children, there's a lot of things interfering. I quite often say that we talk a lot about sleep hygiene and looking after our sleep, but we need to look into the things that we're doing whilst we're awake and that we expose whilst we're awake most of the times as well. So we might need to be looking into the microsleep environment, like how is the sleep surface, the bedding and the position. Is that the issue? Do we need to address that? Are there any other health conditions? Is a child just with an acute illness? Is there a chronic condition that might interfere with their sleep? The development as well, you know, they will go through different stages of the development, and sleep will follow that as well. The emotional side, the social emotional context is very important in children. What kind of routines and practice you have in place, and again, how are those parents dealing with their own sleep and also with their child's sleep. Now, when it comes to the pediatric sleep evaluation, again, caregivers might not be able to recognize some symptoms. So, you know, child might be sleeping already in another bedroom. Maybe they haven't noticed anything through the night. And sometimes it can take a while until they start showing signs during the daytime, or they might not associate that this is a sleep problem. You know, behavioral problems during the daytime, difficulties with attention, common illness. So the child might be, you know, coughs and colds all the time, and they might not pick up that it might be related with their sleep. And unfortunately, there's still things that we don't see, wrongly, but we might not see as problematic, such as snoring. So even during the sleep practitioner course, we say that if a child is snoring, it needs to be taken into account. It's not normal to snore. So a systematic approach to screen the sleep disorder should be included in a component of routine welfare for that help, you know, for that child care. Not only questions around their sleep habits, but also if the parents notice if they're doing something different during their sleep and how they are during the daytime. So it should be a part of that check. And the screening strategy should be appropriate to age and the health condition, again, of the child, if there is any health condition or medical condition present. You know, starting with the sleep history, review said the medical history, like if there are any feeding problems or gastrointestinal problems or any other. What's the development history there, and how things during the daytime, especially if there's a child in school. Family history, the social history as well. Behavioral, doing a behavioral assessment can be included as well. And then again, if we're talking about an evaluation that can be done, for instance, in primary care or in secondary care, physical examination, again, looking at the tonsils, the tongue size, the head, and sleep diaries and logs should be encouraged for the family to follow, or even by the child if we're talking about an adolescent, for instance, a teenager. So I'll show you in a minute what this VAERS questionnaire is about. We also have there are many questionnaires out there, some of them very specific for condition, but some of them just overall quite generic to address, is that time sleepiness, is there any signs of OSA? So there's different ones to address different conditions. I just brought these three because they're quite good and they're used a lot. The Brief Infant Sleep Questionnaire is a lot about sleep habits and sleep behaviors. The Children's Sleep Habits Questionnaire as well, and the Pediatric Sleep Questionnaire. This last one is mainly around the obstructive sleep apnea, snoring, daytime sleepiness, so he ended up compiling several aspects. And the Children's Sleep Habits Questionnaire is it was developed to measure the behaviors around sleep in children from 4 to 12, I believe. So these are just some of them that can be used. I'm going to show you the VAERS. The name, the team basically that developed it came up with this VAERS sleep screening tool to help with what is actually measuring. It's divided in 5 major sleep domains. The B stands for bedtime issues, the E for excessive daytime sleepiness, A for awakenings through the night, R for the regularity, and S for the snoring. So it's just a very brief screening tool to help us to identify if there are signs of any of these major problems. Again, daytime sleepiness, awakenings through the night, and snoring. It's been developed for using children from 2 to 12 years old. And you might see around the questionnaire a P between brackets that is directed to parents. So it's a question directed to the parents. And the C within brackets is directed to the child, of course, if they can answer by themselves. There isn't like a proper score at the end. You're going to see there are a lot of questionnaires and scales that you can add up the figures at the end. It will tell you which bracket the child follows. And this one is slightly different. It should, of course, be put in practice by a trained clinician, but is mainly to help us to identify what might be the problems. It doesn't do any diagnose. It doesn't show us there might be signs of these or that. It just helps us to identify the problems that can be addressed and what recommendations the clinician can give to address them straight away. It's been pointed out as one of the most user-friendly for families to be picked up issues around more towards the sleep disorders in children. I added this just out of curiosity again, is a systematic review with a lot of tools about sleep, the pediatric sleep tools. They basically created, it's quite recent and is an update of literature review around what kind of sleep questionnaires and scales are out there to measure sleep in children, what group they should be used, and what they're measuring. So again, I can provide it later afterwards. It's quite useful. I'm not going to go into detail through this. This is just, I have 2 slides like this, and this is just an algorithm to help with how to address some of the sleep conditions and what are the problems. For instance, if there's bedtime resistance or prolonged sleep onset, what kind of scheme in a way or flowchart we can actually follow to help us address this issue with these families. For instance, let's check first of all if there's a good sleep hygiene, are there any anxiety, especially around bedtime, what kind of things we can do. So it's just very broad example of how things can be approached in a systematic way. And the same here for the night awakenings. What might be triggering or might be at the base of those night awakenings, starting with the point that there's no other health conditions interfering with or triggering the night awakenings. So again, it's just an algorithm to help us to go through what kind of things might be there. Now, when it comes to diagnostic tools, I'm not going to go through all details of that. We probably need another couple of hours. But it's just out of curiosity. Most of the sleep centers, they have a good range of different sleep studies that can be done. I must say there's some big surgeries, the GP surgeries, they're already doing home oximetry. So they're already able to provide some devices that look a bit like this little finger here, attached, of course, to a little device. And the parents can actually measure the oxygen level and the heart rate to 2 or 3 nights in a row. And in a small child, big fluctuations of oxygen levels, for instance, through the night, it could be a very good sign of obstructive sleep apnea, for instance. For example, in Evelina, most of the children that might come from the ear, nose and throat speciality, they start with an oximetry to check if their oxygen levels are all over the place through the night, or if there's specific parts of the night when they might have big dips of oxygen, which might be the REM sleep, because all of the muscles relax a bit more. And actually the guidelines say that if there's a history that is in line with OSA, and if we have these oximetry, that child is probably diagnosed with OSA, and he might go for tonsils and anomalies to be removed. And then we do another oximetry a few months later to see if it's resolved. So apart from the sleep history and clinical history, sleep diaries and questionnaires, we have available to help children in the clinical settings actigraphies, which are these like little smartwatches. We use a lot of this into older children, teenagers and school age, to check actually what the sleep opportunity and what their their routines are. They wear these for 2, sometimes 4 weeks in a row, day and night time, and then we're able to actually see what is going on with their patterns. The oximetry, as I mentioned, that goes on the little finger. The capnography is to check the CO2 levels. We might have some health conditions that lead to carbon dioxide retention in the body, and that leads again to some health complications and daytime sleepiness as well. And this is the machine over here. And then we have what we call the sleep study. So we might have just a simple one that will check the breathing, the oxygen levels on the heart, that we call the cardiorespiratory study. And then we have a full polysonography. So we have a full sleep study where we measure brain activity, muscles, heart, lungs, everything, and even the video and to check behavior. The majority of the times those are done in the sleep lab. The cardiorespiratory, most of the big sleep labs are able to do it at a parent's home. We instruct them how to use it at night, or they can be coming and sleeping in the hospital as well. And this combined EEG and polygraphy, they're usually for cases where there is, for instance, epilepsy present, and they want to see if there's anything on their breathing through the night that might be triggering epileptic crisis, and the other way around as well. And these multiple sleep latency tests, sometimes called as well as the NAP test, this is what is going to help us to diagnose cases of narcolepsy. So basically they sleep with us overnight and then they stay during the daytime. We give them opportunity to do little naps to see if they fall asleep and how quickly they fall asleep. So these are the main sleep studies diagnostics tool that they can, primary care, for instance, and secondary care can refer. Just out of curiosity, this is how a little one will look after we're all set up for overnight full polysonography. And this is all the data that we can collect. So we record overnight everything, and then we analyze bit by bit to see what's going on with that child. And as a curiosity as well, what you see here with these blue and yellow and black lines, this is what we get out of those ActiWatches. Basically, the blue periods are the ones when they are asleep, because there's activity, as you can see here. And then these black little lines are movement, so that's when they're awake. And the yellow line you can see is light. So we are able to see the movement, address the sleep patterns, and see the light exposure as well. But we never do this study without a sleep diary. So sleep diary, even in all the children, they're quite useful. And we always corroborate what we're analyzing here with what the parents tell us or the child tell us they're doing. When it comes to pathway, the majority of the sleep-related problems and symptoms of children, they can be assessed and diagnosed and even treated by some of these specialties. So it could be in the primary care. It could be pediatricians working in general community or in other health facilities like the mental health service. Referrals, these can also refer to specialized sleep centers. Of course, that everything works in different tiers, but for instance, Evelina will get referrals from different specialities in the hospital, but also from the community. Unfortunately, if the referrals come from families or from non-NHS GPs, they sometimes they're not accepted. For other departments, they might notice, if a child is being followed by nutrition, for instance, in a big hospital or just in a community hospital, if the problem is mentioned to other specialities, basically to other doctors, they might be able to refer for sleep study for them to address. Quite often we get, and we and other sleep centers, we get referrals from secondary care, from specialities within the hospital and outside, from ears, nose and throat, respiratory, from allergy teams, surgical specialities as well, and metabolic as well. So again, they might notice that the health conditions might be related with something else like sleep. Some of them, they're very comfortable requesting the sleep study straight away, like the ENT and respiratory. Some of them might actually ask for a sleep consultant appointment with their family first before they choose the right diagnosis method. And just as a reading recommendation, the Clinical Guide to Pediatric Sleep is a very good book. We use it in clinic. I recommend it all the time. And just out of curiosity, a book I came across years and years ago, and I found it hilarious, the title, but it's actually a very good book, is Stop the 1 and 100 Other Sleep Scales. It basically compiles a lot of sleep questionnaires and sleep scales for adults and pediatrics. It shows what they're measuring, how to score, who came up with a questionnaire. So it is a good compilation as well. And that's it. That's what I brought today.
Excellent. Thank you very much, Anna. That was very full on, lots of information there. So I hope everyone found it as useful as I did. We did have one question come through during the session, so I'll just read that one out. So if a child snores but no other symptoms, would you always need a medical check?
A very good question. We always advise to have, to at least to take it to primary care, to GP, to have it checked. If a child is snoring, that means that on the upper airway, we have some limitation into the airflow. We might see signs even during wakefulness. We might see they're sometimes breathing with their mouth open, or they might have a blocked nose, and that's why they're snoring. But also, it might be also that the adenoids and tonsils are quite big. So whilst they're asleep with all the muscles relaxing, basically the airway, instead of having this size, it will come to this, so that the air going through, it will make some noise. So if it's a flow limitation into the breathing, that might lead to awakenings throughout the night, because the body might not have all the oxygen they need, or they might not be able to exchange the gases as they need. So especially if you notice that the child is coming out of their snoring at some point, that means they're triggering very small awakenings, what we call the arousals, that might be interfering with the sleep architecture. So I always say, at least take it to GP for an evaluation. They can check, the nose, check the adenoids, tonsils, the tongue size, and check a few other things. And sometimes symptoms just start later on, especially if it's a small child and they sleep a lot during the daytime. We might not notice that there is a excessive daytime sleepiness. So I would say to always check.
In terms of this session, it was quite specific in terms of sleep disorders, and obviously Anna, with her background, has gone into just touching into some of the experiences that she's had as in a kind of clinical setting, so looking at those diagnostics and those kind of things. So hopefully that's given you guys a kind of a sense of not only what you should be looking out for, but also what happens beyond kind of your boundaries and more in a clinical setting. So it kind of gives you more context. If you are interested in more of this kind of area, then feel free to contact us and let us know what areas are of interest to you, because we're guided by what people want to be able to put on sessions like this and other courses to meet the needs of our students. Okay, so it sounds like, or it looks like we haven't got any other questions. So that just leaves me to thank you all for coming and attending, and thank you very much, Anna, for running this session.
Thank you, Chris. Thanks, everyone.
Thanks.
Thank you for watching our video. For more London School of Childcare Studies content, see our social media or visit our website childcarestudies.co.uk.